Hey everyone, and welcome. In this explainer, we are diving straight into the practical side of managing urinary tract infections. The whole point here is to give you a clear, useful guide that you can literally use in your daily practice. We want to arm you with the key info you need for every single patient conversation. So let's get right into it. Okay, so before we even start talking about specific drugs, let's just ground ourselves in the why. Why are we doing this? Every prescription you fill, every piece of advice you give, it's all aimed at these four things. It's not just about stopping the pain, right? It's about preventing a simple UTI from turning into a nasty kidney infection, stopping that frustrating cycle of recurrence, and of course, making sure we have safe outcomes for our pregnant patients. So here's our game plan for today. We'll kick things off with your role, then we'll walk through the whole clinical process, how to classify the infection, how to choose the right initial therapy, and then, the really crucial part, how to counsel patients on those first-line drugs. We'll also spend a little time on some special populations, and then wrap it all up with the most important pearls you can start using tomorrow. As pharmacists, you're right there on the front lines, and you play such a huge part in antimicrobial stewardship. Your expertise is absolutely essential for making sure the right drug gets to the right patient for the right amount of time. It's all about using these antibiotics effectively and, just as importantly, safely. So let's get into our first clinical step. Not all UTIs are created equal, not by a long shot. Is this a simple, uncomplicated bladder infection in an otherwise healthy woman, or is it something more complicated? Is there a catheter involved? Knowing the answer to that question is going to completely change how we approach treatment. Now this chart, this is basically the foundation for everything we do with empiric therapy. I mean, look at that. The vast majority of these infections are caused by good old E. coli. And that's why our first-line drugs are chosen so specifically. They are laser-focused on knocking out that one main bug. For those patients who keep coming back with UTIs, you're going to hear these two terms, relapse and reinfection. And knowing the difference is actually pretty important. A relapse, that suggests the first antibiotic didn't fully wipe out the bug. But a reinfection, that's a whole new bug, causing a brand new infection. This really changes how we think about what to do next for that patient. Okay, so that brings us to the big question. How do we choose that first antibiotic? We're going to focus on the scenario you see all the time, acute, uncomplicated cystitis in women. And here they are. These are our go-to options straight from the guidelines. We've got four really solid choices here. And notice the best part? The short durations. We're talking 5 days for nitrofurantoin, just 3 for SMX/TMP, and even a single, one-time dose for fosfomycin. All of them are great against E. coli. Now this is something I really want you to take away from this. For so many years, fluoroquinolones were the easy answer for UTIs. Well, not anymore. The guidelines are super clear. For a simple UTI, these drugs should be on the bench. The risk of creating more resistance, plus all those serious side effects, it's just not worth it when we have better, safer options. And when you're thinking about using SMX/TMP, you have to put on your detective hat for a second. This is a hard and fast rule. You need to know your local resistance rates. If the E. coli in your area is resistant to Bactrim more than 20% of the time, you really should be reaching for something else, like nitrofurantoin or fosfomycin. All right, let's get super practical. Knowing the drugs is half the battle. The other half, where we really make a difference, is in the patient conversation. So what do you need to tell them when you're handing over that prescription? First up, one of the most reliable workhorses in our toolbox, nitrofurantoin. So here are your must-haves for counseling. Number 1, always tell them to take it with food. It helps with absorption and it's easier on the stomach. Also, give them a heads up that it might turn their urine a brownish-orange color so they don't freak out. Stress that they have to finish the full 5 days, even if they feel better after 2. And the big clinical point for you, remember, it's a no-go if their kidney function is poor, specifically a creatinine clearance under 30, because it just won't work. And while it's rare for these short courses, it's good to be aware of the risk of lung issues with long-term use. Okay, next up, let's talk about SMX/TMP, or Bactrim, assuming your local resistance rates are in that safe zone. So with this one, your absolute first question before anything else is, are you allergic to sulfa drugs? That's non-negotiable. Next, tell them to drink plenty of water to keep things flushed out. Give them a warning about photosensitivity. They'll need to be careful on the sun. And another important one for you to keep in mind is the risk of high potassium, especially if they're older or also taking something like an ACE inhibitor. And finally, let's cover our single-dose wonder, fosfomycin. The biggest selling point here, as you know, is adherence. It's one and done. Make sure you tell the patient to mix that whole powder sachet in a glass of water and drink it right away. It's super convenient, but it is worth mentioning that some data suggests it might be just a tiny bit less effective than the multi-day drugs. Still, it's a fantastic first-line option. Okay, let's shift gears now and tackle a couple of the trickier situations you are definitely going to see. Patients with those frustrating recurrent infections and patients who are pregnant. Both of these require a little extra thought. For recurrent UTIs, there's a pretty clear playbook to follow. First, just make sure they actually meet the definition. From there, your role is to help them understand the options. You can talk about things like patient-initiated therapy, where they have a prescription ready to go, or maybe postcoital prophylaxis, if that seems to be the trigger. And for some, long-term low-dose antibiotics might be the answer. Now, pregnancy. This is where we have to be extra careful. As this slide shows, even a UTI without symptoms has to be treated to prevent complications. Generally, our safe bets are beta-lactams like amoxicillin or cephalexin. We absolutely positively avoid fluoroquinolones. And we have to be cautious with nitrofurantoin and SMX/TMP. We avoid nitrofurantoin right at the end of the pregnancy, and we avoid SMX/TMP in both the first and third trimesters. Wow, okay, we have covered a ton of ground. So let's finish by boiling all of this down into the most important high-yield pearls that you can take with you on your next shift. Here they are, your 4 biggest takeaways. Number 1, don't treat bacteria in the urine if there are no symptoms, unless the patient is pregnant. It just breeds resistance. Number 2, for simple cystitis, stick to those short courses. 5 days of nitrofurantoin, 3 days of SMX/TMP. Number 3, keep those fluoroquinolones on the bench for simple cases. And number 4, if someone is really sick, think sepsis, or they can't stop vomiting, they need to be on IV antibiotics. And that's a wrap. So I'll just leave you with this question to think about. The next time you have a patient consultation for a UTI, how are you going to apply these pearls? What's one thing you might do or say differently? Thanks so much for your time today.